Okay, so we are going to get started. My name is Betsy Torres. For those who don't know me, I am the Associate Director of the Continuing Education Office at SUNY College of Optometry. And today's program, we are putting it together because we are in a dire time of getting as much information out there. So I'd like to thank you all for joining us. For today, there will be question session at the end. Please send your questions at the end in the question Q&A box. Indicate who you're directing your questions. We have over almost 500 people on this line. We're getting up their numbers. So please make sure that you indicate who your question is going to be directed at. And two, please note that we may not be able to get to all the questions, but we will try to find a way to either answer you in one shape or form, whether it's via email. Everyone that attended today's webinar will also get the recording after the fact in case they wanted to share it with someone. It is also going to be streamed on our Facebook page. And without further ado, I'd actually like to introduce Dr. Richard Madonna. Dr. Madonna, please take it away. Dr. Madonna?
Thank you, Betsy. Give me one moment here. Yeah, you got me?
I got you, loud and clear.
Okay, just got to bring up the slides. Okay, hi everyone. Thank you all for joining us at this unprecedented time. I want to first of all thank Betsy. We started kicking this idea around about doing this last Monday, but because we were just so involved in changing college programs over the course of the week, there was no real time to talk about it. So it was a Thursday at 4 o'clock when I said to Betsy, let's do it. And she was able to pull this together inside of 24 hours. So I really want to thank her for that and thank the panelists who essentially got invitations late Thursday afternoon or Friday morning to be on this panel this evening. And so again, they're giving of their time, and everyone really deserves your thanks and applause. Before I start speaking, I have a very short piece on continuing education. Just a heads up for what we'll be doing going forward. We're looking to put together programs on infection and infectious disease, and obviously one infectious disease in particular, and we're trying to get programs together on that in a very short turnaround time. Secondly, we'll also be looking to put some CE programs out there. I know with the canceling of Vision Expo, people are looking for hours, and we will try to make sure that we're able to give those to you. Okay, so my job very quickly is to talk about COPE and continuing education credits. I am on the COPE governing board as ASCO's representative to that board. We met 2 weeks ago on March the 14th. Not surprisingly, COVID was an important part of that meeting. And this was the, on the left, you see the letter that came out from COPE. And if you haven't seen it, and I know many of you have, essentially it says that COPE has modified their rules for the time period between March 7th and May 31st. My guess is that May 31st date will be fluid. And it says that we or COPE has made changes in their rules and formatting. And the most important thing to remember is if you are giving a course, and that's from our end, or taking a course, that courses that are interactive distant learning, meaning webinar type courses, as long as they are live and as long as you are able to interact with the speaker, be it by voice or by chat or whatever the case may be, COPE will consider those as live CE activities. In the past, COPE has not considered those as live. The bottom box, I think, is extremely important because what it says is COPE is modifying these rules, not the individual state or provincial boards. So it is imperative that you speak to state boards about what this rule means for you. In New York State, we're lucky because New York State a couple of years ago made these live webinar type courses live CE. So not as much of an issue in New York State, but please check with state boards if you have any questions. This is not something you would check with COPE. Secondly, this came out the other day. I got this from the NYSOA, and it speaks to a missive that came out from the Office of the Professions. And what the Office of the Professions said that because of COVID, licensees whose registrations are due to renew from March 1st to June 1st, the department grants an adjustment so that CE 100 up to 100% of CE can be done as self-study. As long as it's taken from a department approved provider. In other words, your sister-in-law can't put together a course on, I don't know, dental hygiene or whatever, and it's an acceptable subject area for the specific profession. So that will help many of you who have had difficulty getting credits. We will also be available, just for a plug, for our CE office, and there are many others providing courses as well. So that's all I have to say, and I want to turn it back to Betsy right now.
Okay. Okay, Dr. McGovern, you're there?
I am here.
Okay, great.
Betsy, we couldn't hear you for a moment there, so we lost
I apologize.
your sound
My
completely.
apologies. So, Dr. McGovern, thank you for joining us tonight, and he'll be giving us an update from the Department of Health. Go ahead, Dr. McGovern. I see your slide.
Sure, great, thank you. So my role at the college, I'm the Chief Medical Officer, which is basically the medical director. So for the last month to 5 weeks, any employee, student, staff who has either been diagnosed with COVID-19, been tested for it, been presumed positive, or has been exposed, I've spoken with. Because of that, I've spent quite a few hours on the phones with the Department of Health, who, you know, most of the guidance comes from either the CDC, the New York State Department of Health, or the New York City Department of Health and Mental Hygiene. So I've been on the phone with all three entities many times over the last month. I will tell you, after all of my experience, the best information, in my experience, is coming out of the New York State Department of Health. So on your screen right now, that first bullet, they have a COVID-19 hotline, and the number is right there. Over the last month, as more and more cases have hit New York, they've added a lot of personnel, and it's been a little more challenging getting definitive answers because they have a lot of new employees on the front lines who are not familiar with the material because it's so new and it changes constantly. So the one little tidbit I will give is they seem to have, I know they have 2 levels of assistance, level 1 and level 2. Level 1 is the first people who pick up. You can explain your information to them. If it's anything technical, they're going to bump you up to level 2. So now I've learned when I call just to get myself onto level 2 right from the get-go. And that's been really helpful because level 2 staff has a lot more information, and it's more professionals who will answer our types of questions, as opposed to level 1, which is patients from the public calling saying they have a cough and they want to know what they should do. So, and also then we have the Department of Health and Mental Hygiene from New York City, not as helpful as a state. I've called them a number of times. I've gotten some basic answers, but every time I ask for very specific answers, they kind of just refer me back to the CDC guidelines. So on this slide, the recommendation is call that New York State Department of Health's COVID hotline and get to a level 2 person, and you'll probably get your best answer possible. Laboratory confirmed positive versus presumed positive. So I can tell you right now, it's very hard for people to get tested. They're only testing people who they think are going to end up in the hospital. So for instance, we have 8 of our community members at the college, either positive or presumed positive, both in the college and at our affiliated sites. Only 2 of them were able to get tested and were positive. The other 6 have been told to presume they're positive based on their symptoms and risk factors and such, but they were told they're not going to be tested because they're not that serious to be hospitalized, not going to be, and just go forward presuming they're positive. So 75% of the people I've been dealing with my very small sample size have been presumed positive. but we're treating them just the same. So as long as a physician gives the indication that this person should consider themselves positive, we consider themselves positive, and we have the same protocol for both. Now, the guidance on contact tracing. So the scenario here is an employee or someone in your office will say that they either went to the doctor and was told they're presumed positive or they're being tested, and they want to know what they should do, and then we have to know what we have to do as far as the contact tracing and informing people they may have come into contact with that they potentially were exposed. So the DOH guidance as of this morning, because I did verify this morning in preparation for today's presentation, was basically that if someone turns out to be presumed positive or positive, you have to find out when their symptoms first started and then go back 24 hours from that point. Within that 24-hour window, you want to find out who they came into contact with if they happen to have been at work in that period. Once you identify who they came into contact with, the criteria now for determining if that person had significant exposure is that either they were with that person for greater than 15 minutes within 6 feet, or they were in the same size room as that individual for more than 2 hours. They don't define the size of the room, but they say these are healthcare providers, so we're talking about office space, basically. We're not talking about arenas or anything like that. So, but it's 6 feet for 15 minutes or 2 hours in the same room, and had to have contact within 24 hours preceding the onset of the symptoms. So that's how we've identified who was potentially exposed and who has to be notified. So now once you identify those people, we basically have to send them home for 14 days to quarantine. As long as they remain asymptomatic during those 14 days, they can return. Obviously, if they become symptomatic, then they become the patient themselves and have to go for testing or at least go to the doctor to find out if they should presume they're positive. DOH yesterday released a less stringent protocol for people who were exposed and or asymptomatic. So where before yesterday it was if you were exposed, you were quarantined for 14 days from when you had that exposure. Now they're saying that if you're exposed and you're essential and that you're needed to maintain operations, that if you're exposed but have no symptoms, you can return to work immediately. And they have some specific criteria such as checking your temperature twice, quarantining when you're not at work, wearing a mask if you're within 6 feet of people. This more relaxed protocol seems to be more geared toward like emergency room staff, where the doctors and nurses and support staff are basically getting sick now, and they're becoming less well-staffed in these facilities, and they need people back on the front lines quicker. So for most of our offices, including the college where I work, we're still going with the 14 days of quarantine because we have the luxury of moving people around and rescheduling and still maintaining coverage. So I don't think we're at the part where we really have to put people at increased risk to maintain operations. But different sites obviously have different requirements and different challenges. So now that we have this official protocol from the New York State Department of Health, if applicable, you can use this guideline if need be. Guidance for a person who is too removed from the positive. So this is a scenario where someone will come to you and say, my spouse just was sent home from work because someone in their workplace was positive, and now my spouse was told to work from home for the next 14 days or a week or whatever it is. What should I do? So you have the patient, the people who come into contact with that patient are 1 removed, and then the people who come into contact with that person are 2 removed. So as long as 1 removed is asymptomatic, the person who's 2 removed from the patient has no restrictions applied to them. So they can come to work, they don't have to get tested, they don't have to quarantine, there's nothing going on unless person 1 becomes symptomatic, because then person 2 is now only 1 removed instead of 2 removed. So that's a very common question we're encountering now, because people are running to neighbors and family members and things like that who are becoming positive or presumed positive. And then there's a concern that they were exposed through a second person. So that's a common question. So 2 removed, no restrictions. So now the next question is, now that we're having these people who were sick and now getting better, is when can they come back to work? So as of the 28th, the New York State Department of Health released a health advisory that said the requirements to return for healthcare workers, for 72 hours, they have to have basically no fever, and that's without the use of fever-reducing medications. There has to be an improvement in symptoms, and they have to have at least 7 days passing since the symptoms first appeared. So this is in one of the advisories, which I'm going to show you in a moment how you can access this stuff to find the information yourself and stay on top of it. But 72 hours, no fever, improving symptoms, and 7 days since the onset of the symptoms. The last thing that I'm getting a number of questions about is screening of patients. So when patients come into a clinic like ours or a private practice, what can you do? So what we started doing about 4 weeks ago under the guidance of CDC is we had flow sheets. So if a patient came in, we would give them a questionnaire. Initially it started, were you in China, Wuhan City, China, or around anyone who now is symptomatic. Then that went to the 5 countries. Now basically being this community spread, all of that's out the window, and people are catching it on trains and in their apartment buildings and in stores and things like that. So we're no longer asking that. So we've modified our questionnaire a number of times. When patients were identified as having a positive finding, we were putting them into isolation and then calling the Department of Health to see if they had to be tested for COVID. But now the testing is so hard and so many people are affected, we've changed our protocol and we have a basic screening in the lobby consisting of more general questions now is, are you feeling well? And if you're not, what are your symptoms? Have you been around someone who's been sick or diagnosed? And then we've also in the last week just started taking temperatures. So now any patient who enters our building, we're taking their temperature. And if they have a fever or a positive response to our questionnaire, we're having them reschedule their appointment unless it's an ocular emergency, in which case we have to put a mask on them and put them in an isolation room to treat. But otherwise, they get rescheduled. If patients come in and refuse to have their temperature taken, we refuse entrance to the building because this is based on DOH protocol at this point. So we do not have to let anyone in the building who refuses temperature. So that's been a good thing and hopefully has limited some of our exposure up in the clinic floors, that they don't get past the lobby. And lastly here, just to show you where I get my information from. So as I said, the New York State Department of Health has been the best resource for me. I go to their website often for updates. So when you go to the website, you're going to look at the Providers Professionals tab right over here. And then when you click on that, actually when you click on this, the first pull down is COVID-19, so it's specific for that then. And then it brings you to this page. Every Thursday, the DOH has a 1-hour webinar that gives updates from the previous week. You can either sign up to be on the webinar live, or on this website, a couple days after each webinar, they're available for the public just to watch at their own time. And this library has all the webinars from the last number of Thursdays they've been doing this. In addition to webinars on this resource page, there's also health advisories. So for instance, this is a health advisory that just came out on the 28th, and the slide we just went over about when symptomatic people can come back to work was right off this health advisory. So these are really important too. And again, they're all archived, so you can go back. If you haven't been keeping up with them, you can go back over the last few to actually find these things in writing. And then lastly, there's been a couple of things, printable materials. We have a number of poster boards in the lobby that I've gotten from here about people, how to hand washing techniques, how to cover your cough and things like that. So the New York State Department of Health, both on their hotline and on their website, has been a tremendous resource for me at the college in helping me navigate how to keep people safe and also to respond when people do have an issue, how we can give them guidance on staying away from work and then when coming back to work. And that's really been my part lately at the college. So I guess I'll hand it back over now to Betsy.
Thank you, Dr. McGovern. Okay, so now we're going to introduce Dr. Raymond Perizzolo. He is the president of the New York State Optometric Association. Dr. Perizzolo?
Hello, can everybody hear me?
Yeah, I can hear you. I think
Okay.
we all can hear you at this point. Go for it.
Great. So,
Oh, I'm sorry. Wait, Dr. Peruzzo, I'm sorry to interrupt you. There are no slides from Dr. Peruzzo. It's just an announcement. Just wanted to make sure no one thought that something was wrong with their screen. This is just, he's just speaking from here. Okay? Go ahead, Dr. Peruzzo. Sorry about that.
yes, thank you, Betsy. I found out yesterday morning that I was going to be doing this, so I put together a few things to update everybody on. When this whole thing broke, we decided at the NYSOA that we were going to put all of our legislative efforts that we had planned to go with this year aside, and we were going to focus on COVID-19, particularly with unemployment and small business bailouts that might be coming from the government. We've been trying to report the information as it's coming, and a lot of things that you hear, how come we don't know how to do this yet, or how come you're not telling us how to do something? The answer is it's changing every day. So before we produce a guideline on how to file for a small business loan, we need to have all the pieces in place. Some of that stuff is coming down from the AOA, which Dr. Thaw is going to make some announcements on. But as far as our orals bill and we're putting that aside for right now. We feel that COVID-19 is way more important, and the interest of our members as far as keeping their practices afloat and what to do if they were laid off or furloughed are of utmost importance at this point. Since COVID-19, the fiasco happened, the governor had put down an executive order that said all healthcare workers and dentists are considered essential essential workers. We were under the assumption that we were in that group, but we wanted to be officially recognized. So we did write the governor's office. We were officially recognized as quote unquote healthcare workers, so we could continue to see those emergency patients that may be coming into our office. And even have our employees at the office to answer some telephones if we needed them to be there. I know that sounds nitpicky, but those are the things that we have to do. We have to make sure that we're included. You can't just make assumptions. One of the other things that came across our radar was there are ODs in the hospitals that are being assigned to phone duty, or some of them are even being furloughed and losing their jobs because it's not in their scope of practice to do some things such as maybe a nose swab to help on the front lines. So at this point, we are trying to get ODs recognized so that they can be deployed and trained in helping in some of those processes so that the administration at the hospitals don't look and say, oh, this is an optometrist, we can't really use them for anything, we're going to send them home. We are also monitoring what's going on with telehealth. AOA did a wonderful webinar on telehealth the other day on how you can bill for Medicare services. Right now, I haven't heard a ton about the other insurance companies, the non-government insurances, on how they're dealing with telehealth. But as soon as we have some type of a guideline, which I'm sure it will be different for every single insurance company, once we have some type of a guideline, we will let you know. The last announcement that I wanted to make on behalf of the NYSOA is that we will be postponing our annual meeting to November 12th through 15th. We were planning on resurrecting that meeting this year. It was going to be the first weekend in June, but because of all of this, we decided that, that's when people might start getting back on their feet again. And we didn't want to try to call people out to our meeting when they were, number one, they may be struggling to get their practice back up again. And number two, take them out of it right when they're starting to get into a groove again. Those are the major announcements from the NYSOA. I will say that as far as questions go, I'm going to direct all questions that any of you may have to NYSOA member services. The phone number for that would be 449-7300. Once again, the phone number is 518-449-7300. I don't want to take questions that I may not know the answer to and possibly give you the wrong answer. Some of this stuff might have to go into our legal department. So I want to just make sure that everything is in the free and clear. I hope everybody is staying safe out there, and we'll try to get as much information to you with as many procedures on how to keep your practices afloat, file for unemployment if you need to. And like I said, if we can figure out a way to get ODs recognized to do some other testing out in the field to help the process. Thank you for having me on this call, and have a good one, everybody.
Thank you very much, Dr. Pirozzolo. Okay, so now I'm going to introduce Dr. Viola Canespi. She will be talking about COVID-19 in your private practice. Dr. Canespi, you can start sharing your screen.
Hi, give me a second.
Yep, take your time. I can hear you loud and clear, by the way. Perfect. Thank you.
Okay. Hi, everyone. Thanks for having me on. I'm going to speak about how my private practice has been coping during this nightmare in the hope that you can take away something that helps you cope in your own practice. I want to start by saying that I've been and continue to be very, very lucky in my life. Even during this situation, I find myself, unlike many of my colleagues, able to walk to work, able to keep paying my staff. I have my husband to help me. My kids are home and healthy. My parents are able to maintain quarantine in their own homes. I have one staff member who can drive in with her daughter so that together they're able to work 2 days a week to give me and my husband a break. I have another staff member who has young kids, and I've asked her to stay home and make calls to patients from there. My younger associate, who's probably listening now, Dr. Siller, has been working part-time at Woodhull Medical Center, and she's one of those doctors that Dr. Pirozzolo mentioned that has been right now relegated to phone duty, but she continues to work there. And she's been able to field telemedicine calls from her home on days that she would normally come in. So everyone's been pitching in and has been incredibly helpful. But most importantly, my patients have been so supportive and continue to call and place phone orders and make teleappointments, which helps keep us afloat financially. I think I can manage this way for about 2 months if I don't take a salary, and then I will take an emergency loan if need be. I know that for many of my colleagues, the situation is worse, and many were furloughed even before their employers knew whether they would lose money or not. When we decided to slow, we slowed our scheduling down to 1 routine patient per hour, about a full week before the CDC made the official recommendation to stop all routine care. It felt honestly terrifying, especially as many doctors on Facebook groups PM'd me that I was overreacting. I cried that night, but then dried my tears and decided to stick to my guns and do what I thought was right for my patients and my family and my practice. Those last few days of trying to cope with office disinfection routines was quite a doozy. I struggled to go over every detail of hygiene I could think of. I have been following the CDC websites, which in addition to the New York State website that was mentioned is also quite helpful. I sent a formal hygiene review to my staff and walked each one through the office going over each detail. I posted this sign in our front door. I set my phone timer to go off every hour as a reminder to Lysol all doorknobs, surfaces, and light switches. And what you see on this slide is my protocol for basic office hygiene, which I'm happy to share, and procedures for allowing scheduled, urgent, and emergent patients into the office. And we've been doing this for, I guess, about 3 weeks now, where we take a temperature as they walk in. I personally came in an hour early each morning to clean the office and left late each night to do it again, not trusting anyone else to keep it pristine. Our protocols during the day included using pens only once and then placing them into a tray of alcohol after each use. Any frames that were tried on went into a red tray, washed in hot soapy water, dried, and then placed into another gray tray into a UV sterilizer for about 5 minutes. The trays were then wiped down with alcohol before being reused. Each exam lane was wiped down with alcohol before and after each patient. But then, to be honest, a few days of this, my hands were raw from scrubbing, as I'm sure all of yours were, and the news was getting worse and worse, and I realized that there just wasn't enough Lysol in the world that would make this a feasible endeavor. And so we made the decision to cancel first all of our high-risk patients, and shortly after that, all routine exams. And the CDC agreed with us the very next day. The letters in these slides were sent to all patients by email, posted on our website, and then on our Facebook page. And I'm happy to share these with you as well. And then we started scrambling. The business had to adapt and adapt fast. I was responsible for my patients, my staff, my friends, my family. Everyone had to pull through this together. So the first order of business was making sure that I could communicate with my patients remotely. Happily, I had done this before with my pediatric patients and was used to the setup. So the fact that Medicare relaxed the rules made it that much easier. The AOA, as Ray mentioned, hosted a telehealth webinar almost immediately so that I knew how to code everything for those patients who would be submitting their visits to their insurers. The NYSOA had an emergency meeting to ascertain what help practices needed, what help independent contractors needed, and most importantly of all, to make sure that optometrists were included in the definition of essential services during this crisis. Once that was done, we started contacting our patients to reschedule, making sure that each one had an adequate supply of contacts or functional glasses to get them through the next 2 months. And we did, as many practices are doing, extend their expired prescriptions if need be. I no longer wanted my staff using the subways, so I told them to stay home, but needed to keep them on salary and occupied, so I had to find tasks that they could accomplish from home. Turns out the AOA has a whole slew of courses for optometric staff on their iLearn platform that I had never seen before. So I signed them up through the Optometric portal and started to put my membership dollars to good use. I then pulled the numbers of all of our patients who are over 65 and had staff call each one to check on them. We've been maximizing use of our downtime to accomplish tasks that we have never had time for during normal operations. For example, we use our own EHR system created by my husband, and he has been using all these free hours to update it and add useful features. My son added texting capability to our recall system. My staff has been organizing and replenishing contact lens trials, doing deep cleaning, and yes, my husband even cleaned out his closet. Finally, we pulled all of our patients due for their annual exams in the next 2 months and are now calling them to schedule exams 1 per hour to maintain separation, starting very optimistically for May 1st. While the staff was busy with all that, I sent emails to every GP and every pediatrician and walk-in urgent care clinic in my neighborhood. Several responded almost immediately, and I've seen several referrals already with flashes and floaters. And of course, we updated our website, answering machine message, and Facebook page, keeping constant contact with our patients throughout. And finally, I have to say that without the support of my classmates, my professional associations and organizations, I don't think there's any way I would have been able to weather this storm and emerge sane. They have been calling in to check on me, telling me about loan programs, shared work programs, webinars, virtual happy hours, sharing patterns for homemade masks, recipes for healthy meals, you name it. Like I said, I'm one very lucky duck, and I believe that if we can all just keep treading water for a little while, helping each other and sharing strategies, eventually we'll be able to reach dry ground and emerge stronger for the struggle.
Thank you for that, Dr. Konecki. I really appreciate it, your time. We're going to present now Dr. Soden, Richard Soden. He will be presenting on integrating telehealth into your practice, telemedicine, billing, and coding. Dr. Soden, you can start sharing your screen, and I believe you should be unmuted. Let's just make sure. Okay, you are unmuted, Dr. Soden. Go for it.
Okay, Good evening, everybody, and hopefully everybody's coping as best as possible during these challenging times. Several of my colleagues have alluded to an AOA webinar that was put on earlier this week or the end of last week. And I've taken some of those slides that I want to review with you regarding the coding and billing of telehealth services. I'm also going to spend a little bit of time about Medicaid and managed Medicaid because I know many of us see those patients also. But let me start out by saying that the AOA has done an incredible job in getting us the ability to perform telehealth and getting CMS to include optometry in the definition of some of the new emergency laws that are going on. So I'm going to talk first about Medicare, and then I'm going to move on to what I believe some of the commercial carriers are doing, and then ultimately talk a little bit about Medicaid and some of the other concerns that you should have regarding COVID-19. Medicare was issued a waiver.
I'm sorry, Dr. Soden, to interrupt you, but I haven't started sharing your screen, so I'm not sure if you started showing your slides. Can you do that?
I did share my screen, and I am showing my slides.
Oh, that is your slide. I'm sorry, I didn't change mine.
Okay.
Because it looks like it's my slide.
No,
I apologize.
Oh, okay. We should all be good. So,
can everyone confirm that, Dr. Soden, switch your slide? I apologize for interrupting you, but I do think it's still showing my slide.
Dr. Soden, I'm still seeing just.
Yeah, so it is still my slide.
okay, so what do I need to do?
Okay, so
I'm looking
you
at
gotta go to the bottom.
It says.
Did you hit click share on the bottom?
Yes, do you want to continue? Yes. How about that?
There we go. We're starting to see now. You can put yours into presentation mode.
Okay. So basically, I'm going to go back to the beginning and start over here. Basically, Medicaid gave a waiver, and it's called an 1135 waiver, that took many of the rules that were currently exist in the federal program and actually laxed them. And I'll talk about that in a few moments. The Health and Hospitals Office of the Inspector General also said that they were going to waive a lot of the rules when it comes to collecting co-payments and not penalize people for telehealth visits that are currently in place. I need to caveat this discussion by saying that we have a Medicare director or a medical director in the New York area in jurisdiction J, which encompasses many areas, who is actually challenging the fact that optometrists are defined as physicians under the Medicare program. I was on the phone with AOA for a good portion of the time on Friday, and they wrote a very, very impressive letter to CMS. So hopefully this will be resolved this coming week or very, very soon. I'm going to go ahead and assume that this is going to be allowed. He seems to be the only medical director that feels this way from my understanding, and many of our other colleagues in the rest of the country are not having this problem. So just remember that, and hopefully we will get that information out. AOA will get that information out. NYSOA will get that information out. There are basically 4 different types of telehealth services that optometrists might be involved with. They're virtual check-ins, e-visits, telephone services, and telehealth services. The rules vary depending upon Medicare, Medicaid, and commercial establishments. So I'm going to try and go through each of these really, really quickly and hopefully explain it in a way that makes sense. Medicare has always been paying for virtual check-ins. They do not define virtual check-ins as telehealth, all right? And I'll go over that a little bit further on. The caveat is that a virtual check-in cannot be related to a medical visit in the previous 7 days and does not lead to a medical visit in the next 24 hours. All right, the patient has to verbally consent to the telehealth virtual check-in. The deductibles and coinsurance must be collected, maybe in all services, but they have waived that requirement. So if you decide to not collect a copayment or a deductible, that is waived and the OIG will not come after you. There are two basic types of virtual check-ins. One is a telephone check-in, one is a captured video or an image check-in. A G2012 is a brief communication technology-based virtual check-in by a physician. And again, we are defined in statute as physicians, even though our Medicare carrier or medical director is challenging that, who can report an evaluation and management service that's not going to be involved in the past 7 days and is not going to result in a visit. It's usually 5 to 10 minutes. Telephone calls are consistent and can be utilized with this code. It unfortunately reimburses a small amount. It's about $15, but it's 5 to 10 minutes. If a patient sends you a recorded video or an image, and this can be done through an established patient by a store and forward system, and again, it's within 24 hours and there are certain rules and regulations, you can also bill for this virtual check-in. Typical reimbursement for this is $12. And it appears that you can use both of these codes during the same visit. So if you talk to a person and he sends you a picture or a video of himself or what he's concerned about, then both of these can be done in the same time. You have to get verbal approval, so which would mean on your encounter form, you would indicate verbal approval received. All right, and again, you can bill both of these at the same time. Medicare also pays for online digital evaluations, which is the way that patients will communicate with a doctor without an office visit via a patient portal. So for those of you that do have patient portals and EHRs and you can connect, these are the codes. These have to be established patients as opposed to the, when we go a little bit further on. By the way, the virtual codes also have to be established patients. These concur over a 7-day period. You would use the 99421 codes, which I'll talk about on the next slide. Deductibles and coinsurances will pay, but they can be waived. Also, previously this had to be done through HIPAA compliant platforms, neither of which was things like Facebook or if you want to do it via Skype, but the waiver has included that these are okay during this emergency period of time. The codes are pretty much the exact same codes. There are 3 of them, and they're all based on time, 5 to 10 minutes, 11 to 20 minutes, and 50 minutes, and those are the codes that you would use. The third type of telehealth services are telephone services, not the brief encounter, but a much more elaborate encounter that would take place. Medicare does not cover these types of services. They did not cover it previously, and it appears that they're not covering it under this 1195 waiver. Medicare in New York State is covering these, and we'll get back to those a little bit later on. And there are some rules and regulations. They use the exact same codes that you do if you're using a patient portal. And again, there are different levels of services based on time. What has changed is that the normal telehealth rules that used to apply, which meant that you had to be working in a very restricted area, there were not many providers available, there were certain zip codes that they allowed to do this in, have been laxed under the current Medicare system. So if you're going to perform office visits, psychotherapy, consultations, and certain other health services, and the provider is in his office or in another location, and the patient is at a remote site, and there is live interactive two-way communication, these codes can be used during the emergency period of time that's in effect because of the coronavirus. So Medicare allows for these, which used to be only restricted to certain areas. Here are all the places that you can actually provide them. The patient could be in his home, he could be in another location, you can be in your office, or you could be in your home or another location. These are typically the 99,000 codes. They can be used for new patients as well as established patients. It would, in my opinion, it would be very challenging to do a level 4 or a level 5 for an established patient or a new patient, but these codes are included for all professions. You typically have to use the GT modifier and the 95 modifier. Explain those in a moment. The place of service is 02, which means that you're doing it telehealth-wise as opposed to 11, which is an office visit. The reimbursement rates are the rates that you would get in your office. Modifier 59 is synchronous telemedicine service via real time. Modifier GT is with synchronous telecommunication. Sometimes they want both codes, sometimes they want only one code, and there are, again, the .02 services. So again, Medicare has also waived the ability that the doctor doesn't have to be within state, they can be out of state, and other things that are going on. This is all retroactive back to March 6th of what's going on. HIPAA rules have been laxed during this period of time. As I mentioned before, you can use basically most technologies, FaceTime, Skype, or anything else. Don't use Facebook Live, Twitch, or TikTok because those are public-facing communication services, but Apple FaceTime, Facebook Messenger, video chat, Google, Skype are all allowed during this period of time. This is a pretty good chart which talks about what Medicare is doing. And again, the caveat being that one of our current medical directors is challenging whether we can do it, but I believe with the help of both NYSOA and AOA, we can get over this. Many insurance companies are following the exact same rules that CMS has put in place during this emergency time. United Healthcare just came out with a telehealth process that's going on. It may vary depending upon what plan in telehealth in United Healthcare, and most other insurance companies have the exact same rules that CMS. If you're interested in a carrier, you may want to call them specifically and understand what's going on. My opinion is that they don't usually follow the telephone services, the 99441 to the 99443, but they may cover the virtual codes that includes the online call also. So you always want to check with your carrier. Medicaid in New York State, traditional Medicaid, if anybody still sees patients, they have actually been covering synchronous telehealth services since February of 2019. You would be billing the 9900 codes. If you take out your CPT books, there's a section in the back that talks about telehealth services. Things such as fundus photography, vision therapy, 92065 are not included on this. So this is basically for office visits. During the coronavirus emergency, they are covering telephonic services. And as optometrists, we are allowed to do those 99400 codes that I spoke to you about a few minutes ago, 99441 to 443. They do not cover the virtual services. So this becomes a little bit confusing to get a handle on everything that's going on. Managed Medicaid should follow the exact same route. I'm not sure what the vision care plans that administer some of the managed Medicaid plans are doing, so you may want to check with some of those. But in New York State, synchronous telemedicine services have been allowed. They will continue to be allowed if you meet the criteria. They will not pay for non-synchronous times that are going on, not even during the emergencies. AOA has suggested that doctors of optometry seek clarification from their insurance companies, from their malpractice companies, to make sure that telehealth services are covered. The AOA malpractice policy does include some of these, so you may want to check with that. If you determine that you want to offer telehealth services, sometimes people are blocking out times in their schedules and doing it during certain times. Others are treating them as an emergencies. If you're doing it while you're in your office, you may want a quiet, dedicated space. If you're doing it from home, you may, again, want a place that's quiet and everything that's going on. Documentation has to be in your record. When you finish with this, you enter the encounter form. You can bill with the various different codes. And if you have any questions, you can always email me. And also, it's very important that you write down verbal permission obtained from patient for this procedure. You may also want to update your voice message and send a message to your patients notifying the availability of telehealth-based care. Telehealth-based care, again, has to meet medical necessity rules. So refractive issues are typically not going to be covered for Medicare and commercial carriers, but may be covered for Medicaid carriers. So I know I covered a lot of information about coding and billing. If questions come up, let me know. This is an opportunity for us to really get involved as a profession in telehealth. I believe that after this epidemic passes, we will wind up using this in our practices, continuing this. Healthcare has gone a long way with telehealth services, and it may become a significant portion of our practices. So I wish each of you good health during this crazy period of time, and I'll be around to answer any questions should you might have. Thank you.
Thank you, Dr. Soden. Okay, and up next we have Dr. Andrea Saul. Dr. Saul will be giving us an AOA update. Dr. Saul, please unmute yourself and start sharing your screen. Thank you.
Hi, can you hear me?
I can hear you loud and clear.
Excellent.
If anyone has any sound problems, just let us know and we'll look at it. But right now you sound clear to me. Thank you.
Fantastic. Thank you so much for having me this evening. It's really an honor and privilege to be here and to share this time with all of you, my optometry family and AOA family. As we all know, and all of my colleagues just detailed, it is a new and uncharted world for us. But we are all blessed to be facing this challenge in the age we are in now, with tools that enable us to keep connected, to learn and grow together. Even when we have to be physically distant ourselves, it is incredible. And I think we are all learning so many amazing things about each other and what we can accomplish even under the most trying times. That is what I know we are learning at AOA. Clearly, as a family of doctors, we knew how important the care we deliver is and how critical it is to work together to advance that care, whether on Capitol Hill, in each of our states, or in the media and with patients. Just as the rest of the world is changing before our eyes, AOA is also shifting focus to ensure that we're able to continue to provide care. Right now, AOA is clearly focused on fighting for and delivering the resources we need as a profession to continue providing the urgent and emergent needs of our patients, as well as those resources we need to weather this storm, because we will weather it and return to providing the full spectrum of care our patients trust us to deliver. AOA is definitely taking a long-term view as we tackle this virulent challenge, and I'm honored to share the important wins and initiatives that have achieved and brought to life to set us up for success. We are all frontline providers of essential care, and today AOA is laser-focused and moving quickly to mobilize its public awareness, advocacy, and clinical resources into support of its member doctors and their practices in the face of the coronavirus pandemic. From the moment COVID-19 took hold of our nation's health and attention, and recognizing the importance of optometry's full inclusion in all federal health legislation, AOA swiftly went to work on Capitol Hill as the first emergency aid package started formation, overcoming the constant efforts of medical interest to insert restrictive physician definition language. Even at late stages of Capitol Hill deliberations, the AOA successfully ensured that doctors of optometry were fully recognized as physicians in the sweeping $8.3 billion package signed into law on March 6th. We took the available information and, knowing that doctors needed to understand the updated coding and billing nuances, quickly assembled an instructional webinar that Dr. Soden referenced earlier. The session, available online at AOA's Coronavirus Hub, was attended by thousands of doctors seeking to continue to provide care as the nation began implementing community spread countermeasures, including the closures of schools, businesses, and institutions. And last week, AOA worked to ensure that doctors and optometry practices across the U.S. will be immediately eligible for emergency loans and other crisis relief support under the $2.2 trillion economic rescue package signed Friday. The bill included measures that support doctors as well as provide some student debt relief options. We will continue to fight at the federal and state level to protect and advance optometry's role in this constantly changing and unpredictable environment. While securing recognition and relief as legislation advances, the AOA board worked quickly to identify short-term and long-term ways the organization can help set doctors up for additional relief and future recovery. Last week, AOA and affiliates announced the profession's crisis relief and recovery plan consisting of immediate AOA dues relief. All AOA's dues are waived for 2 months for all members. Immediate dues and assessment freeze. AOA dues and assessments are to be maintained at current levels through at least 2021. Immediate program reprioritization. AOA is dedicating an organization-wide response to the immediate crisis-related concerns of doctors and affiliates, extending all AOA advocacy activities, communications, AOA Excel, practice tools, and more. Direct affiliate support. AOA is establishing a $500,000 fund to assist distressed affiliates and establishing long-term relief for doctors. AOA is working to establish an AOA Foundation Recovery Fund to aid optometry practices in partnership with industry friends. As the current public health situation evolves, the AOA Board of Trustees agreed to continue working closely with affiliates to determine the specific further steps that will be needed in the days, weeks, and months ahead. As the world progresses through this time, members will receive additional detail to these actions. While the situation is unprecedented, the AOA has the strength, the resources, the reach, determination, and know-how to be the relentless advocate doctors need to help the profession navigate this crisis. The AOA will continue to closely monitor all developments and actively participate in the U.S. public health discussions regarding COVID-19's response to keep optometry apprised of the latest information and guidance. Doctors of optometry need not only understand the risks and current public health situation, but also have the latest clinical recommendations and guidance for informed patient care. Considering the seriousness and evolving nature of this pandemic, the AOA launched a comprehensive COVID-19 updates page where you can quickly locate the latest updates and guidance from AOA and U.S. public health authorities. The site, AOA.org/coronavirus, includes a multitude of resources that are being updated daily and information about the wins I talked about here, as well as future wins that we will secure. This week, there's more to come, but immediately this Tuesday at 9 p.m. Eastern, AOA will host the next webinar on what doctors need to know about the new sick leave and FMLA requirements and financial support options for practices. You should definitely tune into this and future webinars that we are starting to assemble, including some for relief available for student debt. We all know that optometry is stronger when we all work together. And right now, in this moment of crisis, we have truly put that sentiment to the test. I am proud to be part of this strong, dedicated team of professionals and know that together we will persevere. If you are not already an AOA member, we need you to join the AOA family because, as you can see, AOA is fighting hard for optometry and our patients. Thank you.
Okay, thank you, Dr. Saw. I also wanted to just mention one thing. Today is Dr. Saw's birthday, so happy birthday, Dr. Saw. Thank you for taking the time. This is a moment that we are going to answer some of the questions. Actually, a lot of the questions have come in. I want to just, if you guys give me maybe a minute or so while I gather myself, some of the questions actually have already been answered via the chat box, but I also wanted to see if any of our panelists wanted to answer them live so other attendees know what was answered to the question. There are some questions for Dr. Soden. If you open the Q&A box, you're able to see that. I did want to answer one question regarding the live Florida courses. When it comes especially to the human trafficking. So this is a two-part answer. Florida has not made any adjustments to their rules as far as live and distance learning. They do not, at this moment in time, they do not accept what they considered as distance learning, which is even a live webinar or recording of a webinar. They don't accept that as a live CE program. I'm not sure if that's going to change. Our office does plan to have the human trafficking course at our Envision conference. At this moment in time, we're still trying to find the right person. There are certain criteria that the presenter has to fulfill. Cannot be just an optometrist. It actually has to be someone who is qualified to teach that course. So we are trying to get that right person. Once we have that information, I guarantee you I will put it in an email and send it to anyone. If any of my panelists want to log on right now and kind of start to answer some of these questions, that would be great. Anyone available?
Hi, this is Dr. Konevsky.
Go ahead, Dr. Konevsky.
I wanted to answer Naomi Noller, who asks to clarify guidelines for soft RGP and scleral lens use at this time. And anyone can chime in terms of the panelists if they have other information. Right now, what I have been telling my patients, and based on the guidelines I can gather from AOA and from the American Academy of Ophthalmology, is that, of course, if they wear scleral lenses, if their lenses are necessary, medically necessary for vision, and they wash their hands and use the proper disinfecting protocols, which most of my patients, by the way, are using peroxide for that, hydrogen peroxide, and their regular surfactant cleaners, then yes, they should continue to wear them. Correct, if they're not feeling well, they should not wear them. And then in terms of soft lenses, before this started, when the kids, most of my patients are pediatric, the kids, when they were going to school, I did ask their parents to have them wear glasses because I didn't want them touching their eyes during the day, since contact lens wearers generally touch their eyes more during the day. But now that they're home, I've lifted that restrictions, and I've sent my patients a letter saying that if they're feeling well and they're home anyway, and they want to wear their contacts and they are washing their hands well before and after, I don't see any reason that they shouldn't be able to wear them, especially as most of them wear daily disposables.
Betsy, we have a number of questions in, so let's just run through them here. So here's one for Dr. McGovern. I know a couple of these have been answered online, but I think we should throw them out there for the general audience. How does your screening protocol change, if at all, when someone presents with shortness of breath as a symptom? Michael, you on there? I'm not sure. Is he coming through okay?
Okay. Let me just see if he needs to be unmuted. Maybe he's just having some difficulties there. Let me unmute his phone. Dr. McGovern, you're there?
I'm here. Can you hear me now?
There we go. That's
Hear
better.
you now. Perfect. Great. Thank you.
Oh, perfect. So the protocol initially was we had staff members with a laminated sheet asking about 5 questions when it first started. In the last week, now that it's gotten much more serious and, as a threat because the number of New Yorkers with COVID is increasing, we have to be more vigilant in the lobby. We actually have faculty members scheduled to staff the table down there. So the question was about if someone comes with shortness of breath. So when we had a staff member asking those questions, it was tough because that could be chronic COPD or that could be something very acute that's related to COVID. So we were challenged, and as far as getting the right answers by having non-medical professionals ask the questions. In the last week or so, since the doctors are staffing the lower lobby, it's become much easier because a lot of the questions can have answers that make sense if you know the proper follow-up questions to ask. So we've now switched it over to the doctors, those follow-up questions are getting asked, and we're better at our screening technique of getting people in who are safe to come in and turning away people who are sick.
Thank you, Dr. McGovern. The next one up is for Dr. Konevsky, but I think probably a number of people might be able to answer this one. How will we know when we can resume routine eye care? Or are you waiting for the CDC to change their recommendation? I don't know if everybody or no one can answer that, but Viola, you want to
Sure.
jump in?
Sure. Probably no one can answer that. My sister is an epidemiologist and infectious disease specialist working with Pfizer developing vaccines. So I take a lot of guidance from her. Honestly, I don't think we will be able to resume normal patient care, meaning, a patient scheduled every 15 minutes or a half an hour, anytime in the foreseeable future. In my own practice, I plan to start scheduling patients on May 1st, but only one per hour. I have 2 exam lanes, so if you have more and a larger practice and are able to separate them physically that way so that you can clean the exam room before and after, well, then I think that's probably as normal as we're going to get for a while.
Yeah, thank you for that. Here's another one for you. Are you aware of any details about the Paycheck Protection Program from the stimulus bill? Will this apply to optometrists? And
I'm not sure what program that's referring to. I know that there
yeah,
are many
anybody
programs
on that one?
that are up in the air right now. I know that I personally have applied for an emergency loan from New York State, but they haven't even responded as to whether or not they've gotten my application. So I think everything's kind of up in the air now.
Dr.
I just want to
Thaw?
let the speakers know, the other panelists, that you are unmuted so that you have or at least try to unmute yourselves, because I'm not able to do it right now, so that you can help chime in with these questions. So I know Dr. Sona's unmuted. Okay, good. I think we're okay. So go back to the answering questions. Thank you.
Andrea, do you have anything to add to that?
No.
Okay.
I just, in terms of when we open up the practice, I think we're going to have to wait for guidelines from the CDC. AOA will give some advice as well, but we need
How
to do
about the
what's safe
Paycheck
for our
Protection
patients.
Program? Anybody?
Are you talking about the shared work program?
I'm just reading the questions, so
Right.
I can't go further with that.
Right.
Yeah. Okay, the next question's for Dr. McGovern. What device are you using to check temperature?
So we have currently been using a non-contact thermometer that's aimed at the forehead. We've used it for a week now. The issue we're having with it is that it's coming with very low temperatures, like 92s, 91s, 88s. So we thought it may have been just because people were coming out of the cold, but people have been going back down, and we're using 2 different devices. So I think Viola had mentioned on the answers that we're typing in that she's using a contact thermometer one. So I actually want to know if she was having better success getting more accurate readings.
Those generally are a little bit more accurate, although I have to tell you, they all read a little bit low. So what I do is first of all, normal temperature is not really 98.6. It's more like 90, for many people, for normal temperature is 97. So if I'm getting a 98.6 or higher on that thermometer, I consider that suspicious.
Okay, and we're using, just so people know, we're using a temperature of 100 or more as a fever.
Right, I use 99 and up as a fever at this point on those types of devices. The oral ones and the anal ones are more accurate.
Kathy Mastroda's just added, we are now using tympanic. So thank you, Kathy, for that. The next question goes to Dr. Soden, but probably anyone could answer this as well. Historically, a patient would call and discuss a medical issue with me at no charge. It is going to be odd asking patients to pay for a phone call. Interesting question, kind of a real life question. So I'll just open it up to the panel on that.
The virtual codes, the G codes that I referenced a few minutes ago, I think are more than I have a problem with my eyeglasses. But I think if you're rendering medical care, those codes are there to be used. They will remain there for both for Medicare and many commercial establishments after the coronavirus crisis goes over. Medicaid, as I referenced, never uses those codes. I don't know what will happen with the other telephonic that I spoke about, because traditionally Medicare did not cover those 99441 codes. So I think you have to look at the codes. I think you have to understand that they are there. If you feel that you're rendering appropriate medical care and you meet the definitions of those codes, they're perfectly acceptable. The caution I would give you is that it's not for patient A and it is for patient B. It should be an all-in-one decision as to whether or not you want to do this for all your patients, because again, one could criticize that you're only doing it for those with insurance. There was also a question that came up about the use of the 99241 to 42 codes and also the 9900 codes. Whatever the definition of the code is, you have to fulfill that definition. So if you're doing a 99213, you have to have the appropriate level of examination, the appropriate level of medical decision-making and the appropriate level of history. You got to go back and review those slides. I would imagine most of us are going to be doing either a 99212, which has a decision making, or a 99213, or a 99202. I think it's going to be very challenging to go above those levels at this particular time. So hopefully I answered those two questions.
Any other panelists want to jump in on that, or?
I'm going to jump in for a second because I
Yeah,
have been
please.
doing this, and I do
Yes.
agree. It was very uncomfortable for me at first to tell patients that, well, you know, usually I talk to you on the phone about this and not charge you anything. All of a sudden, there's a charge. But we did send a letter, which I had in my presentation. I'm happy to share with you, explaining to patients that we are available for FaceTime. And I think they're very understanding. And I still will take the phone call when they call and try to answer it. And basically what I do is, if it'll take me more than, you know, a couple of minutes to really talk to them, and I feel like I have to see the eye, then I ask them to get on the phone with my staff member, who then takes a credit card in advance and explains to them that there will be a fee for the visit, and that they have to initiate the call and call my FaceTime. And we schedule it like we schedule a regular appointment, and they've been very receptive and have not had a problem, and actually very thankful that I'm able to do that.
Thank you. That's a great answer. And I'm just going to pull something over from the chat, and perhaps Dr. Soden can answer this. If we want to call our patients over 65 that might be at risk for COVID to establish if they should be tested or not, is that billable for telehealth, or just our choice to do so or not, but not billable as it doesn't directly pertain to their eye care?
I would say the answer is no, because most of these services require the patient to initiate the service to the doctor. All right, these are not practice management. These are not designed for you calling every patient in your office. These should pretty much be generated by the patient who has a concern, calls you up, and then you decide to do it in one of the telehealth platforms. I don't believe you should be doing it the other way around.
Thank you for that. The next question, Dr. Soden, is Medicaid covering telephone visits? By telephonic, I mean visits that do not include virtual photo/video.
During the coronavirus epidemic, or pandemic, I should say, that 99241, 242, and 243 are going to be allowed traditional Medicaid, which should also be managed Medicaid. When the pandemic is over, I don't know what will happen, if they will continue that process or not. But they do not cover the virtual codes, but they will cover those telephonic codes.
Great. And Dr. Soden, we've gotten this from a number of places. Would it be possible to obtain your slides or the documentation slides, or some combination of that question has come in from a lot of different places?
So first of all, I would recommend everybody go to the AOA learning platform, because the full presentation that was given by Dr. Rebecca Wortman, who is an expert in this area, is available on that. If it's not there yet, it'll be there in a day or two. I can work with Betsy and get some of the slides that are specific to Medicaid put together in a couple of days, and I can get Betsy to post them someplace.
And everybody will be getting the recording as well, so you
Right.
will have the opportunity to grab that. Here's another. For us to use the telemed E&M codes, does the examination need to meet the same standard of care as an in-person exam?
Yes, telehealth is really a mechanism to be performed whether the person is in your office or whether the person is remote. So whatever code you choose, you have to meet that criteria. So again, I believe that a level 2 or a level 3 is probably all you're going to be able to do in an established patient, and probably a level 2. You got to go back and look at the criteria for each E&M service. They have specific, whether it's the complexity of the case, whether it's medical decision-making, or a whole bunch of other things going on as well. So be careful, be sure to do that.
Okay, thank you for that. Dr. Thor, if we pay our dues for the whole year up front, how does the 2 month of free dues work for that situation?
We are here for our members. We're all in to try to do whatever we can do to try to help make it easier. Those 2 months dues can be forwarded towards next year, so prepaid for next year. If you're having other issues or concerns about the dues, you can contact the NYSOA directly or the AOA directly, and then we'll be able to make individual adjustments as need be.
Thank you. This question, it's more of a comment, and I appreciate it. I appreciate much information has been given for New York. Will state-specific associations do their own webinars to address per state? Not sure if this can be answered, and that's right. I don't think we can answer it. I would hope they would, because every state is a little bit different. We, of course, focused on New York State today because we are a state. We are the State University of New York. Next, Dr. McGovern, what type of PPE are the interns and doctors using while doing emergent urgent exams?
Sure. So naturally, we're trying to practice the judicious use of PPE just because, as we're all reading about, there's really a severe shortage in places that truly need it. So, so when this first began, we were just more or less relying on social distancing, constant hand washing, things like that. The providers who were being called down to check patients who were symptomatic, I actually had them fit tested with the N95 respirators. The personnel from downstate came, gowns, face masks, gloves. Now that it's getting more serious and we're screening people in the lobby, we're hoping that we're not going to have so much exposure on our clinic floors, but I have allowed the people who are on the front line, such as the lobby staff who come in contact with everyone, to wear gloves and a surgical mask at this time. But normal interns and doctors on the floor seeing asymptomatic patients, we're really just trying to practice social distancing. We got the breath shields for the slit lamps. And cleaning of devices, but they're not wearing surgical masks. Asymptomatic doctors caring for asymptomatic patients at this time because that's the indication from CDC. It's really for sick patients and the doctors and caregivers working with those sick patients only.
Anyone else want to comment on that? Okay, next one. Just throwing this out there with regard to contact lens care and guidelines. Recent study, March Ophthalmology, shows no evidence of the virus in tear samples collected from 17 patients from day 3 to day 20 of active symptoms. Transmission through tear considered low. Note, conjunctival sample not performed. So take all precautions, but don't fear the tear. That's the kind of thing. The next program we're looking to put together, that's the kind of thing that we absolutely want to address. I saw a paper today about tear transmission to nose. So we'll try to pull something together regarding that. So thanks for that question.
Hey, Rick, I would also...
go ahead. Yeah.
I would also add that for those of you that don't get AOA's first alert every single day, that's a great source of some interesting articles that they're putting up. They did put up one yesterday. It's a free service for everybody. And it has a lot of information about what's going on with the coronavirus and webinars. So if you don't subscribe to that, this would probably be a good time for you to think about that.
Thank you, Dr. Stone. This is Andrea Sola. I can echo that. AOA has a lot of important information, and I have seen research articles that do say that the virus is contained within the tears and that actually viral conjunctivitis may indeed be one of the early signs that comes in a day before some of the other symptoms, as is loss of smell and loss of taste. So I think at this point we need to be overly cautious with tears and touching eyes and just be really careful. Better safe than sorry.
Next one. So is there a difference in what codes to use for telephone versus televideo visits? It's a Soden question.
Again, there are two different code sets. There's the virtual code sets, which reimburse very small amounts. The second code really talks about sending an image or sending a video. So those are good for Medicare and for commercial carriers, I believe. If you're going to be doing a true telehealth visit using the 9900 codes, that could be incorporated into that, but there's got to be an interaction between the patient and the doctor. There's got to be a live interaction to bill the 9900 codes. For the telephonic codes, the 99441, which Medicare is covering, which Medicare is never going to cover, but which Medicaid is covering, then you can include that in a telephone conversation, and that's based on time. So it gets a little confusing with the different rules that are out there. But you know, you gotta, if you can get it straight in your mind, you can use videos, especially with the virtual codes.
Thank you, Dr. Soden, for that. Next one's a very interesting question. How should we pay our staff, full-time and part-time, during the time the office is closed? Viola, you want to start that one?
I mean,
Put you on the
to a
spot.
large extent, this is obviously a very personal decision for each practice and depends very much on what kind of staff you have, whether or not you're able to keep them occupied during this time, and really, frankly, how much cash do you have sitting in the bank? So I mean, there's no two ways to get, you either can pay them or you can't. My decision personally has been to pay them as long as I have cash, and then take a loan and continue to pay them, because while I might have some savings and I'm still okay, they live paycheck to paycheck, and all of them are the primary wage earners in their homes and have small children. So I can't, in good conscience, furlough them. What that means is, you know, I have not paid my taxes yet this year, and I have not paid into my profit sharing plan this year, and I had that money set aside. So for now, all that money is going to go towards paying their salaries. And in the meantime, we've been sort of holding our own. I don't know how long that can last. There is that shared work program, which if I think you can furlough your staff something like 60-40, and instead of putting them on full unemployment benefits, the state pays part of their wages and you pay part of their wages. There is that new program that you can take a loan, and as long as your staff is still employed 3 months later, I think it's something like that, then that loan will be forgiven and considered a grant. But again, a lot of these things are up in the air. So my personal feeling, again, is that if you can keep your staff on salary, you should do it. It's, you know, part of the responsibility of a private practice is to support the families that depend on it.
Thank you for that. That's a very comprehensive answer. And I think, you know, everybody has some very, very difficult decisions to make. The next question is, I'm going to throw this to Betsy. How many total online live CE courses does New York allow?
Okay, so this is kind of going back to, I'm not sure who has their computer unmuted, so if anything, because I'm hearing myself echoing.
Yeah, there's some background noise from one of us, I think.
Yes.
There we go.
So this is kind of a multi-answered question, or a question that has multiple answers. So this is in general. New York State does allow 9 distance learning and the remaining as live. However, as Dr. Madonna mentioned earlier, you are able to attend, as long as they're approved by New York State, attend all 36 courses, 36 credits as live credits in a webinar that's live or in person. And in person, the definition varies from New York State to COPE. For us, New York State does not require COPE credit. If you're a New York State licensee and you need to do your renewal, you can attend a course at one of our webinars that are live, and that will count towards your 36 live credits. Now, if you are due to renew your registration between March 1st and June 1st, they're making an exception that you can do both a combination of, in all of 36 hours, a combination of distance learning and live credits. So if you can attend live events, whether they're live physically or live webinars, you can do them distance learning on a webinar or anything self-study. So again, I say that it's a kind of a full, hefty question to answer, but you can do at this point in time, if you are due to renew your registration between March 1st and June 1st, you can do most of it, all of it, if anything, distance learning, meaning a post-exam goes with your course. However, we do have live webinars, and that will still count as your live webinars. If your registration is due after June 1st, you can attend all of your 36 hours through live webinars, but they have to be approved by New York State. Courses presented by the college, the CE office in pertaining, are or approved by the state are able to count towards those 36 hours. I hope that question does answer. If you do have any more questions, you can call me at 212-938-5830 or email me, and I'll be more than happy to explain it. I know it can be a little confusing.
And Betsy,
Dr. Madonna?
And Betsy, I would just add that they have to be in ocular disease and pharmacology. Those rules.
Thank you. That is the most important part. They have to be in that. And now your 4 hours, your 2 hours of New York State infection control does not count towards the 36 hours. That is separate.
All righty. The next question is, what if a patient comes in and fails the screening and is sick, and maybe we check specific oxygen level and it is low? Can we refer them to a primary or the hospital and bill for that pre-screen time?
Richard, do you want to field that?
I was wondering. That's a difficult question. Interesting question.
There is a modifier in the back of the book of modifiers that says an exam was started and had to be interrupted for a specific service. I would say the answer to that question is probably no, because if the patient came into your office and was sitting in the waiting room and then got sick, I don't think we would bill for that. So my gut feeling is the answer is no. I haven't seen anybody ask that question before. It could probably be a level 1, maybe a 99211, which doesn't even require the presence of a physician. So that would be like a blood pressure check in a physician's office. So I would use that if you decided to bill it all, but I would not use any of the other codes. The telehealth codes have to be in a different location. I would stick to that 99211 code, which is a very low reimbursement code. It may not even pay for you to bill that. It's so low reimbursement.
Okay, the next question is, Dr. Soden again, is there a sheet or resource to review criteria for the E&M codes?
Sure, you can go to the National Government Service National Government Service thing. If you give me, if you send me an email, I could send that. Just bear in mind that whatever we're doing right this moment is dramatically changing in January of 2021. The entire E&M system is changing, but I could get you some information on, it's out there. If anybody needs it, just shoot me an email and I'll put something together. But it's all on the National Government Service website. You can just talk about E&M coding guidelines. I believe AOA has it on its website. They have excellent charts.
Thank you. The next question, maybe Betsy will jump in. Can you suggest sites where we can obtain CE credits, live webinars, while many of us have this extra time? I'll just say the SUNY CE office is one place. I don't know if you want to add anything, Betsy.
I think that, we are a community, and I think everybody has to be able to get as many programs as possible. And I would love for you to attend anything that has any involvement with the CE office, because it's such a close community. However, the Review of Optometry does have courses. Our website currently has, I believe, 8 to 10 distance learning courses. We are in the process of putting out more distance learning as well as live webinars. And then I'm kind of just going to chime into the other question that was asked about what is the difference between distance learning and live. Distance learning is something that already happened, and it's not happening in the moment. The distance learning would require for you to either read or listen to something and then answer questions. That is where the difference between live and distance learning. For COPE, they require something different, but that has been made an exception. So right now, anything that is live, whether it's a live webinar or a live course in person, which we're not doing, will count as live credits. Our office is planning to host several programs while we don't have conferences happening. It is my goal to try to turn these around as soon as possible, preferably within the next 1 to 2 weeks. But just look at our email, on our Facebook page, as well as our website. Dr. Madonna, I'll hand that back over to you.
Thanks, Betsy.
You're
Let's
welcome.
see. Oh, yeah, and you mentioned the review of optometry, which does have a booklet that has all of the programs that were going on. Obviously, that's probably changed quite a bit recently.
Yeah, they host a lot of distance learning and live webinars on their page. And there are several other, I think the only one that comes to mind to me right now is the review of optometry. Med Etiquette is another one, but they're mostly distance learning, not live.
Correct.
Also, AOA has courses on our iLearn platform, and we'll be working hard in the short term to launch many more CE programs to provide CE for our members.
And I think Dr. Thor, that's a great point, because I think if you just browse some of the websites from our major organizations, you're probably going to find things in state organizations and so forth, because everybody is recognizing the need right now.
The other thing I forgot to mention, I'm sorry for cutting in, the local society, OSCONI, the New York Optometric New York State Society is hosting their, I'm sorry? New York City. The New York City Optometric Society is hosting their their monthly meeting through Zoom. I'm the MC of that program, and I believe it's April 7th. It's on our sunieops.edu/CPE. You can register through Eventbrite. It'll send you the Zoom information. It is 2 hours of continuing education there as well. So those are the ones that I have right now that are live.
And I'm going to chime in that we have extended those to be free to all NYSOA members, not just OSCONI.
Right. Thank you, Viola. What is the website called to get updates every day for everyone? I think Dr. Soden, that was the AOA email.
First look.
Yeah, AOA First Look, and I would
there's two
strongly.
different things. The website is aoa.org/coronavirus, and you should check that every day. And what Dr. Soden was referring to is that AOA members can receive AOA First Look emailed to them each and every day. You can log into aoa.org under your profile and make sure that you choose that. And it is a critically important thing to look at inside the AOA First Look. It includes summaries of articles that relate to optometry and health. And within the blue box that's in the center of that piece, it has special messages from AOA to you. And that's what Dr. Soden was indicating. And it's important for you to make sure you're receiving AOA First Look. Again, a free benefit to every member. And be sure to read it, and in particular, the blue box in the center with the message.
I agree. I read it every day. It comes in at about 8 o'clock every morning. Next question is, can you review the modifier for Medicare versus private information?
Yeah, modifier 95 seems to be the modifier that Medicare, Medicaid, and carriers are using. There's also the GT modifier, which may not be necessary. So again, I think the guidance I can give you is if you're doing telephonic or you're doing telehealth systems, use modifier 95, use the place of services 02. When the claim comes back, it may very well ask you for additional information. But I'd rather you give them the two that I'm aware of, which is 95 as the modifier and 02 as the place of service. If that particular insurance company has a peculiar way of processing claims or a unique way of processing claims, they will send it back. But I think if you start adding lots of different modifiers, it's going to confuse the claim.
Dr. Soden, didn't GT get deleted?
GT may be deleted from CMS, but it may not be deleted from individual commercial carriers yet. So it's still a little confusing.
Thank you.
The next question could be for probably either Dr. McGovern, Dr. Konevsky. Would UV lighting be effective to sanitize the office equipment?
So it depends very much on which office equipment you're talking about. It depends on the UV light that you have. UV light bulbs are notoriously short-lived, and I think they're rated for X number of hours, and if they've been sitting around in your office for a long time not being in use, they're probably not good anymore. So that's kind of a difficult question to answer. It would be nice if we could all kind of wave a magic wand all over the office and kill everything, but chances are not. So if you're trying to disinfect frames, then you would have to still wash them first with hot soapy water and run them under depending on the device you have, the recommended number of minutes for that device under a UV light, but that bulb would have to be replaced fairly frequently.
Dr. McGovern,
And I
you have
haven't seen
anything?
any guidance on UV lights effectiveness against the coronavirus.
I have seen guidance. I can probably pull that and find it for you.
And that
Specifically
would be
for like
something.
duration and everything?
I'm sorry?
Specifically for duration of exposure to the UV light?
Yes, but again, it depends on the bulb.
Right.
There was
Well,
some
I'm sorry, Andrew,
mention
go ahead.
coming out of China. Hi, there was some discussion coming out of China of some motorized devices that were going to shine UV light that were able to move into rooms. And remember, you still have to be careful with the UV in terms of exposure to your staff, in terms of visually and in terms of their body as well. So, again, we don't have specific guidelines for use in the office.
Yeah, the frequency of the UV light that's being used is actually safe for vision. I have to find the article for you guys. I don't have it right now.
That would be great. And that's the type of question that I think at the next program we're looking to put together. That would be a great question for that program. Let's see. Okay. This is an NYSOA question, and Ray's not on, but Viola, you might be able to handle this, or Andrea. Many of the NYSOA members send a number of checks dated over time for their dues. If the AOA is delaying the next 2 months' payments, how is the NYSOA handling this?
We had a long discussion about it, and I think we're still trying to figure out what's going to work best, but we will definitely make some accommodation for all types of payments. So maybe you'll have a credit for the next year for 2 months, or we may allow people to ask for a refund, or if they don't need it, they won't take the refund, but we will definitely take that into account that not everyone pays in the same way or at the same time.
Perfect. Thank you. The next question and comment is regarding a source for non-contact thermometers. Many local pharmas have them available for sale to health providers. They don't have them on the shelves. That's more of a comment and a very useful one, I would think. I don't know if anyone has a comment regarding it, but thank you for that comment. Okay, the next.
By the way,
yeah.
Same thing goes for those of you looking for alcohol for your practices. I've stopped into my local pharmacy, and he actually holds bottles of alcohol and gloves for me in the back, so that if I run out, he does hold for local providers, and just ask him and he'll sell it to you. That's not out on the shelves.
Great advice. The next one is interesting. Will SUNY be waiving fees for continuing ed courses? I can't really answer the question right now, but it is something that we have discussed. We have to recognize that we pay the state to run our office, but it is something that we have put under discussion. Dr. Heath would have to be involved in those discussions, but we are doing everything we can to take the current situation into account. The next question is that added to the exam code? I think that refers back to the question about the screening in the lobby and sending patients to a practitioner or to the hospital or whatever. Richard?
Again, I think you can do the 99211 code. Again, it's not telehealth if the person actually shows up there. So the only code that I could possibly see you using, you can't use the 9200 codes because it's just I don't know, you haven't done anything, including you haven't even taken a history. So the only code I could possibly think of is the 99211 code, which doesn't require the presence of a physician and reimbursement is probably 15 to 20 bucks, maybe.
Thank you. A comment just came in. It refers back to something that was said already, but I'll just read it. We are using UV with a UV protection shield to sanitize rooms and to recycle used N95 masks. N95s are labeled by provider. So I'll just throw that out there as a comment that came in. Okay, how do we know if these other CE courses, review of optometry, medicus, COPE, et cetera, that are being offered are New York State approved? The general guideline for that is if, first of all, they have to be in the categories that were mentioned before, ocular disease or pharmacology. If they come from the college and they're in those categories, they are approved. From there, you would probably have to look at who's providing them and grab guidance from the New York State Board. Betsy, do you have anything?
Just to say, just because it comes from the college doesn't mean that they will qualify for your registration renewal. They still have, even if they come from the college, they still have to meet the ocular disease and pharmacology.
Yes, absolutely. No, that's what I was saying. That as long as they meet those and we do them, those are
correct.
Those
then
are
we're fine.
accepted.
Now, if anyone else is providing them, I would say go on the side of caution that they are COPE approved, and then usually the guide that I have been given and kind of give other registrants is use the category that the course was COPE approved under. General optometry is a very ambiguous category, so depending on what is being discussed, that can be justifiable for therapeutics. It really just, I cannot make that determination. That's up to the board to make that determination, but it depends on what is being discussed in that category of general optometry. Anything else that is therapeutic based, they will categorize it as part of your renewal license in therapeutics and pharmacology. Dr. Mazan, I'm just going to kind of chime in. There was a question that came in via email regarding the me going into New York State CE regulations versus COPE. The COPE regulation at this point in time, and I believe it goes in, correct me if I'm wrong, I believe it goes until May 31st. At this time, COPE is allowing what they categorize, or what they normally categorize as a live webinar, they would categorize it as distance learning. They do not identify live webinars on a normal situation as a live course. COPE recognizes distance learning. I'm sorry. COPE recognizes live webinars as distance learning. They only see a live course as in-person. Physically, I can touch the speaker and the speaker can touch the attendees. It's a physical thing, not this situation where we're speaking live.
Well, that's correct, but those laws have been relaxed from March 7th through May 31st. That's the bottom line.
And that was the question that came in. I think the person didn't hear the answer.
That's the bottom line on that one.
Correct. Okay, go ahead. I'm done. Sorry.
No, that's okay. Dr. McGovern, this is a good one. You stated asymptomatic doctors are allowed to examine asymptomatic patients without PPE. Much has been reported regarding COVID-19 infected people being asymptomatic. Does this not present a risk for providers like us who are close to those patients in the course of an examination?
Right. So can you hear me?
Yeah.
Okay. So, as with everything, we try to minimize risk and we go by the guidance of CDC and DOH. So, if anyone goes to CDC or DOH, you'll see that they very distinctly say that they do not want people wearing surgical masks that do not meet the criteria. Even the Surgeon General of the United States has implored people to stop using them because doctors and nurses on the front lines in emergency rooms dealing with positive patients don't have enough. So, everything in life is risk versus reward. And, and we're not saying that providers can't wear them, and especially it's up to their basically discretion if they have a patient. But yes, there is a potential that an asymptomatic patient could be spreading disease. I mean, we all know that. But we do have to follow guidance and we do have to judiciously use the equipment that we do have.
Thank you for that, Dr. McGovern. Next question is, where do we get the UV light devices to clean frames? I haven't the foggiest, so if I don't know if
The one
anybody else does.
I happen to have one in my office. So it looks like one of those nail salon units. Then again, you just have to be careful to know what the rating of the bulb is and how often you have to change it. But they're
Do
not.
you,
They're
do
not
you have
really
any idea where you got it
specifically-
from?
Oh God. You know what? I think we got it when to cure glue to fix frames at one point. There was a glue that was set by UV, so we just got one of those nail salon units to do it, and then change the light bulbs for this purpose. But I'm sure if you look up any nail supply store or online site, they would have those kinds of things.
Wow, very interesting.
I'm gonna chime in for a second here.
Yeah, of course.
Andrew Cuomo just tweeted that New York State has been put on pause, extended to April 15. That means the non-essential workforce is directed to continue to work from home until at least April 15th. We will reevaluate every 2 weeks.
And
It's
the president
not a
just-
surprise.
The president just extended it to April 30th for the social distancing.
Right. So
Kathy Mastroda said she will forward. Oops, it came off my screen, so let me pull that back. Thank you,
Said
Kathy.
she'll forward the UV
She'll
light
forward the
info.
UV lamp info. Thank you very much. Next question. What if I need to do a telemedicine encounter on an elderly patient who does not have a smartphone and is unable to send a photo?
Well, then you could use the virtual code and talk to him. You can use it, again, you can use that for Medicare. You can use that's about all you're gonna be able to do for Medicare, because Medicare doesn't cover the 99441 code. So I think you're stuck with the first G code where you can have a conversation with them. I don't know any other way around that. If you can't face-to-face with them or be synchronous with them, you can't use the 9900 codes. So I think you're limited to that first G code. Sorry, I don't shoot the messenger.
Well, okay. I think that is the last question that's come in. So I think that's a good time to wrap up. So I just want to thank all of the panelists for spending their time this afternoon, and everyone who listened in at this, again, unprecedented time. We will be looking to provide programs as often as we can. And again, I want to thank Betsy, and I'm going to throw it back to you, Betsy, to finish up, and I'm going to mute myself.
Okay. I just want to thank everyone. I know that this is, like everyone's been saying, very unprecedented times that we are kind of gathering. These are important conversations during these times to have. We hope to have many more of these. Well, we hope to have them in the time, but we hope to not have too many of them because we hope to go back to normal. Please look out on our social media, on our website, and our emails on any programs that we have. We want to make sure that our optometric community is well informed of to everything that is COVID and optometric community related, as well as maintaining your license CE requirements. Feel free to email me at ce@sunyop.edu. I am answering them as fast as I can. Thank you very much, and have a good night, everyone. Thank you to all of our panelists who took their time today to participate. Have a good night.